Hi everybody, I am Subhadashini. In this video, I will be explaining about the S2 heart sound, physiology of S2 split and different pathological conditions associated as well. So first let's see about what happens in inspiration. Inspiration, being an active process, occurs due to the expansion of chest wall cavity, and this leads to a decrease in intrathoracic pressure. Normally the pressure is around -5 mmHg, but during inspiration it takes a more negative value, which is around -8 to -10 mmHg, and this pressure gradient causes air to be taken in and also creates a pulling in force. This pull-in force sucks more blood into the right atrium, that is, the venous return increases. Now, as we know, venous return is the blood from the body to the right atrium. So hence I hope it is clear that inspiration is going to increase venous return. Now with this concept in mind, let us move to the heart. Here we have the heart with the right atrium, left atrium, right ventricle, pulmonary artery and aorta, and our focus is on the pulmonary artery draining blood from the right ventricle. On inspiration, as we saw, there is increased blood flow to the right ventricle and this drains to the pulmonary artery via the pulmonic valve. Now let's visualize this down. Take this pipeline to be right ventricle. The bucket that is going to be filled is the pulmonary artery and the stab which can be closed is the pulmonic valve. So normally the blood flows from the right ventricle, passes via the pulmonary valve and the pulmonary artery, and once it is filled to a sufficient amount, the pulmonic valve closes, and this closure of pulmonic and the aortic valve produces a systolic heart sound S2. But now in inspiration, increased venous return. So more blood flows through this pipeline, hence the pulmonic valve will open for more duration to allow filling of this extra blood. So on inspiration, there is increased right ventricular filling, more ejection time, that is, it takes more time to empty right ventricle, and this causes a delayed closure of the pulmonic valve. Why is that so? Because the valve will only close if the pulmonary artery is sufficiently filled to a certain pressure, and this is the key reason for the splitting of the S2 heart sound. So moving on to the representation of the sounds, this is S1. As we know, it is because of the closure of the mitral valve. This is S2 due to the closure of the aortic valve A2 and pulmonic valve P2. So this would be A2, P2 and S1. So now which one do you think represents inspiration here? Yes, the one with the more split due to delayed closure of the pulmonic valve, and this should be expiration. And now this is the totally normal, that is the physiological S2 split. Now that we understood the physiology of S2 split, we shall now hop on to the pathological variations. First, persistent split. In expiration itself, there is a marked split, and hence in inspiration, of course, there is an even more increased split. So this patient has some kind of pathology causing delayed closure of the pulmonic valve, that is pulmonary hypertension or right bundle branch block. So how does normally in expiration itself a patient can have delay in closure of pulmonic valve? This can only be seen if there is some block at this level, that is pulmonary stenosis, where narrowed valve causes slower ejection into the pulmonary artery, hence delaying valve closure. Next, right bundle branch block. As we know, the conduction arises from the SA node to the AV node, bundle of His, and to the right bundle branch. Now, if this conduction itself is slowed, of course, decreased contraction of right ventricle, and that would eventually lead to increased ejection time. So hence, in these cases of pulmonary stenosis, pulmonary hypertension and right bundle branch block, there is persistent or wide split. Moving on to the second variation, fixed split. Here, the split in both inspiration and expiration is the same, that is constant split. Basically, this means that the increased venous return in inspiration has no effect whatsoever. That is, blood flow is somewhat equal during both phases, and that is seen in atrial septal defect. Now we know it is a case of left to right shunt causing increased right atrial volume, increased right ventricle volume, hence more ejection time and causing a marked split. So fixed split is seen in atrial septal defect. Now, having learned that the fixed split is independent of respiration, let us learn about the last and the most interesting type, the paradoxical split. Here, the order of closure is reversed. P2 closes first, that is, delayed closure of the A2 valve is seen. So, patients with aortic stenosis, left bundle branch block would present with a paradoxical split where reversed order of P2-A2 is seen. Secondly, as P2 is normally delayed in inspiration, this moves away from S1, but this delay neutralizes the split. P2 is closer to A2 during inspiration, and of course, this is a paradox. So in this kind of split, the patient establishes two paradoxes. First, the order is reversed, and second, there is decreased split in inspiration. And that brings an end to this video. I hope I made the concept a little easier. Would really like to hear some suggestions from your side as well. And thank you for watching.